Great. We've got a lot of folks on the call, and our presenters have a lot of really interesting and helpful information to share. So if there are questions that we don't get answered during the call, we will definitely follow up with additional information after the webinar. With that, I'm going to turn this over to today's presenters, Evelyn Donahoe and Mary Martin. Thank you.
Thanks, Jackie, and hi, everyone. My name is Evelyn Donahoe. I am experiencing some internet issues today, so I'm going to keep my camera off, but I will go ahead and introduce myself. I am a multi-drug resistant organism epidemiologist here on the Healthcare Associated Infections team at OHA. So I focus on some of our high priority MDROs, including Candida auris, which we will talk about today. And my job is to basically help prevent, detect, and contain those organisms when we find them. And I'm going to present the first half of our slides today and then hand it off to Mary Martin to do the other half. But Mary, I want to pass the mic to you right now so you can introduce yourself as well.
Thanks, Evelyn. Like Evelyn said, my name is Mary Martin. I'm the Region 2 Infection Preventionist for OHA. So I make up just a part of the team of the IPs around the state of Oregon. And like Evelyn mentioned, she's going to start the presentation with her part of it. And then when we go into my half, we're going to talk a lot about the infection prevention and control of Candida auris in the settings that you all work in. So I'm very excited to get going, and I'm going to pass it off to Evelyn to get us started. Thanks for having us.
Evelyn, if you're talking, we can't hear you.
I think she may be having some technical issues. Are we able to, do you have the slides, Jackie, or would you like me to share my screen?
I don't have the slides.
Okay, so let me go ahead and share those then.
Yeah, thanks everyone for your patience while we work through the technical challenges of the day. Okay, I can see your screen.
All right. So let's see if she is able to start presenting.
Oh, now we're looking at a calendar. There we go.
Hey, Jackie, are you all able to hear me now?
We can hear you now. Thank you.
I am so sorry. Thank you, Mary, for pulling up the slides. And I'm going to ask if you can go ahead and run the slideshow. I think that will work out better for us today. Perfect. Thank you so much. So we're going to talk today about Candida auris, which is an organism that we sort of consider one of our priority multi-drug resistant organisms here in Oregon. It's still rare in Oregon, and we're kind of hoping to keep it that way. And that's part of why we wanted to be with you all today to talk about C. auris. It's an organism that's related to other Candida species that you may run into more commonly. It's a yeast, but it's different from those sort of more common yeast infections in some important ways that we'll talk about. Next slide, please, Mary.
Evelyn, I think we may have lost you again.
Can you hear me?
Yes, we can hear you now.
Okay, great. I think there's just a little delay for me. So I apologize and try to make the best of it here. Next slide, Mary.
Are you able to see this next slide, Evelyn?
And did y'all see that go to the next slide? I did not yet.
Yes, we're on the Candida auris, slide number 3.
Okay. Is this the one where the sort of top left bullet point is highlighted, or are all 6 of those kind of bullet points highlighted? Okay, Mary, can you go to the next slide?
Sure. All right, just the one now.
Perfect. Thank you. So Candida auris, like I mentioned, is a yeast. It's a fungus, and it's similar to or related to other Candida species that you might interact with more commonly, but it's different from those in several key ways. And one of those ways is that it can cause serious infections in healthcare settings. Next slide, please. It's also often multi-drug resistant, and some strains are pan-resistant. And what we mean by that is that the antifungal medications that we would normally use to treat fungal infections like Candida auris often do not work against this particular bug. And so for some strains of Candida auris, we actually do not have any antifungals available that would work against it. Next slide. And we mentioned already that it can cause serious infection. This organism is associated with an increased risk for illness and death. So 1 in 3 patients who develop an invasive infection with Candida auris will die from that infection. And some patients are more at risk than others. So we'll look at some of those risk factors on the next slide, please. So what puts patients most at risk for infection with Candida auris? We tend to see folks who have serious underlying medical conditions. So they may be immunocompromised or they're already very sick. They tend to be folks who have long or frequent healthcare facility stays. So they've been in and out of the hospital or in and out of nursing homes or other healthcare facilities. Folks with lines or tubes as a part of the medical care, so catheters, central lines, or folks who are ventilated, for example, will be more at risk. Folks with frequent healthcare worker contact. Ventilated patients are a great example of this, or folks receiving wound care where they are having that more frequent contact with a variety of healthcare workers. Folks who have had lots of exposure to different antibiotics, and then folks who maybe have had some healthcare in another part of the country or another part of the world that has lots of Candida auris. And we'll talk a little bit about the spread of Candida auris through the United States in a little bit, but you'll be able to see that although CRS is still very rare in Oregon, it is becoming more and more common in other parts of the country. And we have seen that, folks travel and may receive healthcare in another part of the country and then come back to Oregon or come back to an area that has fewer Candida auris cases, and that can lead to some spread that way. Next slide, please. There's also serious potential for outbreaks in healthcare settings, including nursing homes and hospital settings. It is most often spread on the hands of healthcare workers or via contamination in the healthcare environment. It has caused some large outbreaks in other states around the United States. Although we are fortunate, I mentioned in Oregon, we've only had a a few cases. In Oregon, we've had one small outbreak that was limited to 3 patients who are all in the same hospital. Next slide, please. I mentioned there can be a potential for outbreaks because of some contamination in the environment. This yeast can persistently colonize patients. And when we say that, we mean that it can live on patients' skin or on their bodies without causing an infection, and it can live on or in our bodies for long periods of time. And we'll talk a little bit more about sort of the difference between a patient who's colonized or a patient who's infected with Candida auris. But for now, I'll mention that for patients who are colonized, meaning they have Candida auris living on or in their body, even if they don't have an infection, they can spread Candida auris to other patients. And this organism can also live on surfaces for long periods of time. And so there have been things like medical equipment and carts that have been implicated in large Candida auris outbreaks in the past. Next slide, please. And then another tricky thing about this organism that makes it a little bit different from other types of Candida pathogens that we see is that it can be tricky to identify with standard lab methods. So not all labs can identify Candida auris, and it can sometimes be misidentified as other species of Candida that are less concerning. And Mary will talk a little bit more about that later on. Next slide, please. Perfect. Yeah, so all of these factors sort of combine to have us label Candida auris as an emerging pathogen threat in Oregon, something that's sort of an urgent and requires our response. And what we have seen, sort of throughout the country is that it can be hard to stop the spread of Candida auris once it really gets a foothold in an area. And so part of why we want to also meet with you here today is to focus on the prevention and thinking ahead about what we can do while this is still rare in Oregon so that we can help keep it that way. In a couple minutes, I'm going to show you some maps of Candida auris and how it's spread across the country. But before I do that, I want to talk a little bit about some terminology that we'll use throughout this presentation just so that we can be on the same page. Patients, like I mentioned, can be colonized or infected with Candida auris. Next slide, Mary. Thank you. So when patients are colonized, that means that C. auris is living on or in their body, but it's not causing an infection. They don't have symptoms, but folks can live like this for a really long period of time, excuse me, months or years. We don't really know how long because it's difficult to track people, but we know that it can persist. Folks can be colonized for long periods of time, and that they can spread the disease while they're colonized. And we also know that folks who are colonized, who have Candida auris living on their bodies or in their bodies, are at greater risk of developing an infection themselves. Next slide, thanks. And then folks can also be infected with Candida auris, and we often call that a clinical case. So, excuse me. This is when C. auris is actually causing an infection in the body. This can often lead to symptoms. Of course, folks can also spread the disease while they're infected, and there are really poor outcomes that we mentioned. 1 in 3 patients with invasive infection from Candida auris will die. So now I'm going to show you those maps that I promised and sort of take you forward in time and watch the spread of Candida auris in the United States. And you'll notice at the top of these maps, it says the reported clinical cases of Candida auris. So these are Candida auris that were isolated out of a clinical specimen. So this would not include folks who were colonized or who are identified as part of a colonization screening. So basically what that means is this includes folks who are identified as clinical cases, and there could be more cases than what are actually shown on this map. And as we move forward in time, I kind of want to have you keep your eye on this central state of Illinois, which is shown in this sort of light yellow beige color near the center of the country here. and just kind of watch what's happening with the state of Illinois as we move forward through the years. SARS was first identified in Japan in 2009 and very quickly spread sort of around the globe. We first detected it here in the United States in 2016 and had a handful of cases in New York and Illinois, mainly in the East Coast. And then if we jump forward just 1 year, we've gone from 4 states with Candida auris cases to 10 states. And you see New York moving into that darker red color, see Illinois moving into that darker orange color. And for the first time, you see other states, you know, all the way on the West Coast and the Southern United States popping onto the map. We jump forward 2 more years now to 2019. You can see more states on the map. We are now up to 15 states, and we see New York and Illinois both reporting over 100 cases that year. So going from just a small number of cases in 2016 to hundreds of cases per year in 2019. And we see California, our neighbor to the south there, jumping into that darker orange color along with Florida. And then 2021, 2 years later, we see now nearly half of states have had at least 1 clinical case. Unfortunately, we do see Oregon jump onto that map with 3 cases from a single hospital outbreak that year. We see more states in those dark red and orange colors. And then last year, we see over half of states have now had at least 1 clinical case. Lots of states in that dark red color, including 2 of Oregon's neighbors, California, Nevada. And we see that Illinois is, you know, among those states who have been in that dark red color for the longest period of time. And so why this rapid spread? Part of it is this organism is particularly challenging to deal with, as we kind of talked about at the beginning. And also, you know, we do think that the pandemic has contributed to this. The Centers for Disease Control and Prevention released a special report in 2022 that talked about how the pandemic had led to an increase in antimicrobial resistance, not just for Candida auris, but also for some other organisms as well. But I do want to point out that on the next slide, that Candida auris really saw a large increase in the number of new infections. So this is just the increase from 2019 to 2020. And we saw a 60% increase in antifungal resistant Candida auris infections starting during hospitalization. So in just a second, I want to jump into sort of a more concrete example of what the spread of C. auris can look like in a healthcare facility, specifically in a skilled nursing facility. But I'll pause here and let Jackie maybe check in on the chat and see if we have any questions or things that we want to address so far.
I am not seeing any questions in the chat at this time.
Okay, thank you, Jackie.
Thank you.
So we've looked a little bit at the national context of C. auris and how it spread across the United States. I want to take this closer look at a skilled nursing facility in Chicago. And that's why I wanted to kind of have you keep your eye on this, on the state of Illinois there. This particular skilled nursing facility had a ventilator unit in their facility. And we mentioned at the beginning that folks having any kind of tubes or lines or indwelling devices, anything like that, can put them at greater risk. So certainly having a ventilator is, you know, one of those things. And if we go to the next slide, I'll just give you a quick reminder of that sort of statewide context, Chicago being located in the state of Illinois, being the largest city in Illinois. So the city of Chicago being home to quite a number of those cases. And we see that increase from 2016 to 2021 from going just 2 cases to nearly 300 cases in just a handful of years. So for this particular skilled nursing facility, they identified one case, a single case of Candida auris in March 2017 on their ventilator unit. So in response to that case, they reported the case to the Chicago Department of Public Health, and the Chicago Department of Public Health came in and worked with the facility to screen the rest of the patients on that unit. So 69 residents on that unit. And so they came in, they tested everybody else on the unit for Candida auris to see if there had been any spread. And they did not find any additional spread at that time. They had that first case patient that they already knew about. They tested everybody else in March and did not find anybody else. But because this was sort of a new and novel organism, I think they wanted to have an aggressive approach. And so what they did was they came back in 2018, so a little over 6 months later, and conducted several point prevalence surveys. And a point prevalence survey really just means that they would come back and test everybody on the unit again to see if there were any new cases. And they decided to do that for both Candida auris and another type of organism that we call carbapenemase producing organisms, or CPO. The reason they decided to do both is because the risk factors for these two types of organisms are really similar. And so often where you find one, you can find the other. So that's why they decided to test for both. And then by fall 2018, they found just over 70% of the patients on the unit had Candida auris. So they went from a single case in March 2017. They tested everybody at that time, didn't find any spread. And then a little over a year later, they had the majority of the residents on the unit testing positive for Candida auris, and you'll see quite a few as well also testing positive for carbapenemase producing organisms. If you look at the next slide, this is just a visual sort of showing that increase. So remember that first case, March 2017, no additional cases at that time. When they came back and tested everybody on the unit again in January, they had 43% of patients on the unit testing positive for Candida auris. They implemented some control measures. They kept coming back and testing folks again, testing everybody on the unit to see if there were any new cases. And you can see by fall of 2018, they had 70% of patients on the unit testing positive for Candida auris. We'll look at this just one more way. This is a map of the unit, and each dot represents a patient. Patients in white are patients who were not colonized, and you can see that that is the minority of patients. The dots in purple, red, orange, and yellow all represent patients who were colonized with Candida auris by October 2018. And the reason there's different colors is because they're also showing that some of these patients were co-colonized with other organisms, and the different colors are showing those different organisms. Like we mentioned, the risk factors for some of these organisms are the same, and so they were testing for both. But you can see here, quite a bit of spread on this unit despite some attempts at intervention. So this really begs the question, we saw the rapid spread around the country. We see this rapid spread in this individual facility as an example. Can Candida auris be contained? Is there anything we can do? And so I want to point out that there are some states that have maintained low number of clinical cases. Oregon being among them, right? We had those 3 cases, and we have not seen any large outbreaks like some other states unfortunately have. And there are other states like that. Massachusetts, Connecticut, Oklahoma, they all had their first case in 2017, but have managed to maintain a low prevalence of clinical cases through 2022. Other states like North Carolina, for example, have more recently identified their first clinical case, but have not seen large outbreaks like some other states. So we are really at this crossroads here in Oregon where we've had a few cases, and we want to make sure that we sort of stay in this category of states that have had a few cases, but who do not see this sort of exponential spread that's really concerning that other states have experienced. And so while we want to work to limit that number of cases to the greatest extent possible, I think it's important to acknowledge that with the spread that we are seeing of this organism in other parts of the country and the world, we are going to see more cases in the near future. It's sort of unavoidable because folks do move across state lines, they receive healthcare across state lines, and so we know we will see more of these cases in the future. And the question really is, will we be ready for that? And how will we be able to prevent and contain that spread?
Hey, Evelyn, we do have a couple of questions.
Sure, I'm happy to pause here and answer some.
Super. So one is for clarity and context, with the 278 cases in Illinois, does that mean there were nearly 100 deaths? Do we have that data?
Yeah, I'd have to get back to you on how many deaths there were from the state of Illinois during that period. That 1 in 3 figure is for folks who develop invasive infection. And so that is really folks who have Candida auris in a part of their body that would normally not have any kind of organism. So for example, they get a bloodstream infection. For those folks, the outcomes are really poor. You can have a milder C. auris infection, for example, a patient who maybe has an external wound, on an extremity, and Candida auris can infect that wound, and maybe not lead to them having an invasive infection. So I don't think that there were that many deaths in Illinois during that period, because some of those infections would not have been invasive. But certainly I think that data is available and we could track that down if folks are interested.
Super. And then we have a hand up from Nicholas Ida. Nicholas,
Yeah, Nick is also an epidemiologist on our team. So thanks, Nick.
Yeah, so I just had a quick question. So with this particular slide, are there other related, I guess, partnerships that we're looking into?
Yeah. Happy to talk a little bit more about that. Maybe I'll go through this slide, and then the next slide we also sort of talk about some of what we're doing, and then we can always answer more questions about that. Does that sound okay?
Sounds good.
Okay. Before I move on, Jackie, were there any other questions?
There are no more questions at this point, so let's keep going. Thank you.
Awesome, thank you. So I wanted to just highlight some of the work that we're doing to try and prevent Candida auris cases in Oregon, as well as other multi-drug resistant organisms. One of the things that we're doing is expanding our healthcare associated infections team, including a dedicated epidemiologist for surveillance of these organisms. That is me. And I have many wonderful teammates who I collaborate with on this work. We're also working to support local public health. We're providing targeted training and webinars on Candida auris and other organisms of concern. So one example, working closely with Nick through the Infection Prevention Champions program for local public health, and also working with individual local public health to provide training for their staff. We also launched the Antibiotic Resistance Information Exchange in October 2022. And this is a system that alerts emergency departments in skilled nursing facilities when a patient with an MDRO, including Candida auris, is admitted, so that those folks can take the proper precautions and have these patients on contact precautions. And then we also work very closely with the Antimicrobial Resistance Laboratory Network, or ARLN. This is our regional lab. They're located in Washington State. And they do our Candida auris testing for us, so we work very closely with them. to detect and respond to any CRS cases that we identify. Next slide, please. And then, really importantly, we are also working really closely with facilities like you who are most at risk of encountering a Candida auris case. So we're working, with long-term care facilities. We've been in contact with other types of licensed facilities like adult foster homes, and we're working closely with folks from acute care hospitals. So sort of across the spectrum of facilities that might run into organisms like this, we're attempting to sort of work closely with you to provide you the information that you need and the resources and support that you might need to be prepared to encounter one of these patients. I'm happy to answer any additional questions that you all might have sort of about the background of Candida auris and the epidemiology of it right now, and then I'll pass it off to my colleague, Mary.
I'm not seeing any questions in the chat, and I don't see any hands raised, so I think we can keep going. Thank you.
All right, well, thank you so much, Evelyn, for going through that first part. Like I mentioned earlier, we're going to go ahead and dive into infection prevention and control of Candida auris in long-term care facilities. And she mentioned this earlier, but we're going to talk about the why of what we're doing. So why are we investing in these strategies now? Why is it important to work on focusing on C. auris? And the big reasons for those are, Candida auris can be really hard to prevent once it has its foothold. It can colonize patients' skin and other body parts for months after active infection has resolved, and can stay on surfaces for many months as well. So strengthening your IPC, your infection prevention and control, can help now. Another benefit to this is that this IPC strengthening can also prepare you and your staff for other MDRO outbreaks, so multi-drug resistant organism outbreaks, much like Evelyn has talked about already. All right, so the main things we're going to touch on today will be promoting, auditing, and enforcing hand hygiene, using appropriate transmission-based precautions, cleaning and disinfecting the patient environment and reusable equipment with recommended products, communicating about C. auris status when a patient is transferred, knowing what to expect if C. auris is identified in your facility or region, and laboratory surveillance of clinical specimens. All right, so we're going to talk about hand hygiene first. First things first, alcohol-based hand sanitizer, or ABHS, is the preferred hand hygiene method for C. auris when hands are not visibly soiled. So this is a big key point here, because a lot of people think, oh, it's a scary bug, I want to make sure that we're washing with soap and water. Yes, it's great to wash with soap and water, but sometimes it's more accessible to use hand sanitizer, and that's completely appropriate with this organism. So we just want to make sure that that's in your awareness, and that you can encourage your staff members to do the quick job of hand sanitizer if they're not visibly soiled at that point. Another thing to mention is that wearing gloves is never a substitute for hand hygiene. We want to make sure that your staff members are doing good hand hygiene before and after donning and doffing, or removing and putting on gloves. And then also the fact that staff need to have access to this hand hygiene. So we do recognize that it can be challenging in some settings, but we want to encourage that you work with your infection preventionist if it is hard for you with your setting to encourage hand hygiene. So like, let's say for instance, you work in a memory care setting and you're worried about your residents having access to that hand sanitizer. You don't want them consuming it or getting into that product. We can work with you to talk about some ideas and steps to make sure it's accessible. And just to recognize the 5 moments of hand hygiene, this is a great graphic done by the WHO with partnership with CDC. And it talks about the 5 moments that we need to make sure we have good hand hygiene. So again, before touching a patient, after or before a procedure. So let's say your patient has a wound. Before you start to unwrap that wound and start doing some cleanup and redressing, we want to make sure those hands are clean. After the procedure, so after you redress that wound, we want to make sure it's cleaned again. And then also if you have any body fluid exposure, so if you're doing incontinent care, any blood exposure, anything like that, you're doing good hand hygiene. Also, after touching a patient, really no matter the situation, And then again, we talked about environment and how important that is. So if you're touching a patient's surroundings, you want to make sure that you're doing some good hand hygiene after that, because you never know what could live on those bed rails or the IV pump or even the walker or wheelchair. All right, so next thing we're going to talk about is transmission-based precautions. All healthcare providers in all settings should be using contact precautions for known or suspected cases of Candida auris. So here's a sign by the CDC. I'm sure you guys are familiar with this, but this sign talks about what's included with PPE with contact precautions. So this includes gloves, gown. We talked about hand hygiene already, but also another important factor is disposable equipment or equipment that's specifically just for that person on precautions. We also want to mention that you can also work with us, your OHA infection preventionists, about questions around long-term patients or maybe those special situations. We may suggest enhanced barrier precautions in your setting depending on what's going on with your case. Again, this is something that we will gladly discuss with you if that comes to be in your facility. All right, so next up, we have our environmental disinfection. So like I mentioned, C. auris has been found to persist on surfaces for several weeks. So proper disinfection is key to reducing transmission concerns. So daily and terminal cleaning is so very important for that reason. We want to focus our efforts on that reusable equipment. So that would be, for example, like a blood glucose monitor or glucometer, blood pressure cuffs, your vital machines, thermometers, anything that's going to be shared from patient to patient throughout the day. That's a good thing to focus on. We also want to avoid equipment sharing to all possible extent. So if we're able to give or use individual blood pressure cuffs per person or per patient, or if we're able to keep a glucometer in that patient's room, that's kind of the way to go. We want to make sure that these things are staying with them and we don't have to worry about sharing this equipment and possibly concerning and causing concern for transmission. So again, it's important to label your equipment as disinfected so the staff know it's ready to use, and also to talk about the disinfection process with your staff. Who's in charge of the disinfection? You know, is there a way to ensure that's being known and that information is shared readily? And again, we're happy to discuss your current processes with you and to help you refine those. All right, this is a graphic that I really love. This graphic was done by the CDC in Project First Line, and it talks about how to read a disinfectant label. So for this environmental disinfection, we need you to use an Environmental Protection Agency or EPA registered disinfectant effective against C. auris. So what that means is that your products need to be on list P. That's the list that talks about disinfectants that are effective against killing C. auris. So list P is the one to focus on. You may have heard of other lists, especially with COVID. List N was a popular one, but this one is specific to what we're focusing on today, C. auris. And if you've ever had an on-site with me, I've probably run around the facility to grab a container or talk to you about the EPA registration number or EPA Reg No, which is what it usually says on the container. And I don't know if you can see my pointer here, but this is a little graphic here. It's a second little bullet point on the screen here on the label. And it just talks about what the registration number is. So if you're wondering if your product is appropriate to kill C. auris, just type in that registration number and you're going to be able to find that information. Another important thing that this EPA number will tell you is the contact time. And I just want to make sure there is clarity with this because this can be a bit confusing with all the different names, but contact time is also the same thing as dwell time or kill time or wet time. All those four names are the exact same thing. And it just means that your product is staying on the surface in that amount of time and wet. So if it's a 30-second dwell time or contact time, that means your product's wet on that surface for 30 seconds at least. So that's a very important thing to understand going into disinfection and ensuring that you have those products available. And then another thing, I put this slide together because these are the most commonly seen disinfectants that I generally see when I'm on sites. A lot of people really like the Oxivir and the Super Sandy cloth wipes. But these are great products, and they're actually helpful with Candida auris as well. So another thing I like to look at too is the dwell time of 2 minutes or less. That's really kind of the gold standard, because you're going to get a lot better compliance with the shorter dwell times. And, you know, having someone do like a 10-minute dwell time honestly is not realistic, especially in a healthcare setting. So we want to make sure that this is a doable dwell time. But these are great products, pretty easily on hand for most facilities, and if not, they are hospital grade and able to be purchased. Okay, so we're going to switch gears a little bit here and talk about the 3 steps for a resident through admission, transfer, and discharge. So let's start talking about admission. So as with any other multi-drug resistant organism, so this could be C. diff, MRSA, anything, admission decision should be based on clinical status and the ability of the accepting facility to safely provide care, not on the presence or absence of C. auris infection or colonization or potential exposure to C. auris. So this is very important. I'm going to say it again just because it's one of those big takeaways from today that I want to make sure that we're all clear on. But the clinical status and the ability of the accepting facility to safely provide care is what's going to help with the admission decisions. So if you're able to provide safe care, which everyone should be based off this presentation today, it's totally acceptable to admit a patient with C. auris or one who's been exposed or has colonization. Again, I also want to mention that we're always hopeful to answer questions for you. So if you have any questions or concerns that you want to address with this new admission, please talk to one of your IPs. We're going to talk more about who they are at the end of this presentation, but we're all here and available to help answer questions if you have those. All right, the next part of this is transfer. So with this, we want to talk about how interfacility transfer notice is required for all patients with MDROs, including Candida auris. So again, this is much like what we've kind of been talking about through this whole presentation, is that, yes, this is specific for Candida auris, but there's a lot of similarities with other MDROs, and this one is included. So we're going to talk about the interfacility transfer form. This is the actual physical form that we just updated on our site, and this is a form you can print off and use to help with that communication process. Another thing to keep in mind with this is that, yeah, it's nice to send a written communication form to the facility, but one of the best things you can do is to do both written and verbal. So pick up the phone, talk to the provider that's going to be giving your patient care. Who's that nurse or CNA that needs to have this information? Make sure that there's a warm handoff and that you're directly communicating with those people. It's going to be the best way to provide the best care for that patient and to advocate for safety of that facility. Okay, and then the last step here is discharge. So based on discharge, the important things here are, of course, to educate your patient and their families about C. auris. So there's a large importance to notifying healthcare providers of their C. auris status. So for an example for this, if you have someone who has a new wound and they happen to have a colonization of C. auris and they're going to a new wound clinic, they need to alert and know to alert their staff member that are at this wound clinic that they have C. auris, that they have that colonization, because this can, again, help prevent against transmission. It's going to help that facility provide the better care with knowing what PPE to use, what disinfectants to put into play with the care. So it's a very important step with that. And then again, hand hygiene. I can never say enough about how important hand hygiene is. It's something that needs to stay in the back of the minds of the patients and their families. You know, it's always important to do hand hygiene. All right. So next focus here is we're going to talk about what to expect when C. auris is identified in your region. So you're going to be getting a notification that C. auris has been identified by the Oregon Health Authority, or OHA, or the Oregon Department of Human Services, or ODHS. There will probably be screening for residents from the facility with an outbreak. And we, again, are strongly recommending proactive use of disinfectants against Candida auris. So again, it's good to have that as part of your routine, so then there's not a big scramble if that happens to come into your area. Okay, and what about what would happen in your facility? So if there's a C. auris identified in your facility, what you would expect would be a partner call with the Oregon Health Authority about or from subject matter experts within 24 business hours. So what we would do is we would discuss the case patient, the next steps going forward, and then recommendations together to collaborate on this case. There would also be an on-site infection control assessment or an ICAR with OHA regional infection preventionists. So that would be someone like me or another IP on our team. And we would focus on the technical assistance and support that we need to provide to help you with this outbreak in your facility. We also talk about resident colonization screening. All right, so what is resident colonization screening? So this is a process where the OHA, IP, and EPI team will work with your staff to conduct a screening of your residents. So I have here a little graphic. This little person has 4 yellow dots, the left armpit, right armpit, left groin, and right groin. And that's the area that you'd be swabbed for this screening. So this is not painful or harmful to your patient at all. It's with this really spongy little Q-tip that you see here in this other picture with the glove and the Q-tip. But this is just done to see if that resident is colonized. So this is something that we would work with your staff to provide and to support. So OHA would give you a call and we talk through what that would look like, how that would work in your facility and what we can do to help support you. And again, as Evelyn mentioned earlier, Arlen will report back with the results and the IP will conduct an ICAR to discuss IPC for your facility. And just another reminder, I know that Evan kind of talked on this and touched on it earlier, but a question that we always get is, what about healthcare workers? Don't we need to screen them too? Well, healthcare workers are not screened generally because there is very low risk if they pose infection or colonization of C. auris. However, it's a good mindset to have because, you know, healthcare workers need to focus on hand hygiene and they could be a possible point of transmission. So in one way, yeah, they need to work on hand hygiene and make sure they're not causing that concern for transmission. But on the other end, they're very generally healthy and there's no real concern, very, very low risk of that being a problem and a need to colonize and screen. Okay, so let's get into the really exciting things, and that is misidentification of organisms. So here is a handy little chart that talks about different methods of screening for different yeast infections. And as you can see on the right-hand side here, these are different organisms that can be misidentified and can actually be C. auris. So this is a slide that I think offers a lot of good peripheral awareness. As IPs, we're another layer of protection against Candida auris in our facilities. An example of what this might look like. So let's say your lab is calling you with a Candida hemolonii, and that was detected on the BD Phoenix yeast infection system. So this one right here. So let's say you have this test that's been run and you're seeing this organism right here. This should trigger a thought about how this might be a misidentified organism and it could possibly be C. auris. So the very next step on what to do would be to call us at OHA and alert us of this lab result. So as you see here, there's a little on-call number, 971-673-1111. This is our on-call number to give us a shout that there's a little concern here. There might be a misidentified organism that could possibly be C. auris. So again, why we're bringing this up. We're flagging to equip you and your team with information about these organisms. If your lab has questions and you don't know how to answer them because this is a bit challenging, you know, this is information that's hard to grasp, please give us a call or direct them to us so we can help answer those questions so that everyone is understanding of the expectation and how we can best be advocates in this sense. Okay, so we just talked quite a bit about what we can do now. So these are the main 4 things we want to focus on. Is your current contracted lab able to identify Candida auris? So we just mentioned that. Does your lab know when to send an isolate for additional testing? So if we're seeing, again, one of those organisms pop up and you've used one of those tests on the other side of the column, please give us a call because we might need to do additional testing. And I want to make sure that your lab is aware of that. So Is that something that your lab understands? Next one is, does your current cleaning and disinfection solution work against Candida auris? So again, if not, stock those products now. We want to make sure you're prepared just in case, because as Evelyn said, it's coming. You know, this is something that is very likely to be seen in our facilities in our region, in our state. So again, is it on list P? If not, find some list P items. The next thing are gowns and gloves accessible to staff. If not, ensure PPE is available where it will be used. And just to kind of bring up past experiences with COVID and other things, we've had facilities alerted of a need for contact precautions at like 2 o'clock in the morning on a Saturday. If this were to happen at your facility, would your staff have the immediate access to PPE? Would they know where and how to find this? Is it locked up? There needs to be 24/7 access and ability for staff to have correct PPE. So that means that you make another key or have someone on staff at all times who's in charge of PPE. That needs to happen now. And then lastly, are staff familiar with contact precaution procedures? If not, establish regular training that allows staff to practice donning and doffing. These are very important things. Staff may have gotten a bit burned out from the COVID pandemic, but these bugs can still very easily spread. So we need diligent and correct use of PPE. Admin and IP should work together on regular trainings for all to ensure proper use. All right, key concepts in the last few minutes. We'll wrap up here quickly. Candida auris is a yeast that can cause serious, hard to treat infections. It can be spread person to person via contact or with contaminated surfaces. It's very rare in Oregon, but still poses a threat. It can be safely managed in long-term care and other settings if appropriate actions are taken. Please visit CDC's Tracking Candida auris website for updated case counts if you're curious. And then additionally, spread of C. auris in long-term care facilities and other settings can be prevented, like we mentioned. Check with your lab if they can identify C. auris. Please start the initiation of disinfectant use that is effective against C. auris in your facility now. Ensure that strong PPE practices, hand hygiene, and appropriate precautions are in play as well. And then immediately report these cases to local public health and OHA, because again, OHA, HI team, we're here to help with preparedness and response. Here's a nice little contact information slide. Again, these will be sent out so you can reach out to us if need be. And then, like I mentioned before, these are the lovely IP team that's all over the state to help out. So again, we have Therese Finn, who's in Region 1 here. Region 2 is me, and then Rachel Geisler is Region 3 and 5. We have Megan Lutt, Region 6. Region 7 is Elizabeth Johnson, and Region 9 is Pamela Bruin. So if you have any questions, please feel free to reach out to your IP members. We're all here to help out. And with the last 2 minutes, I'd love to open up for questions.
So I am seeing a couple of questions in the chat. One has anyone done the homework for products which are on both EPA list N and list P? So we don't have to use multiple products multiple times, etc.
Yeah, so actually great question. Those 3 products that were on the slide that I put on there, they're actually good for COVID as well. But like mentioned, you need to look at the contact time for each organism. So it might be 30 seconds for COVID, but it might be a minute for Candida auris. So you definitely need a cross-reference for each organism.
Super. And then there was another question in the chat that Becca helpfully answered. The question was, is contact PHE in place for respiratory Candida auris, or does this become similar to COVID with droplet / contact? I'll share Becca's great response. So generally transmission-based precautions for C. auris are focused on contact precautions as it typically spreads via contaminated hands, clothes, equipment, etc. If you have a resident with active respiratory symptoms, masking may be warranted if close contact care, splash, or sprays anticipated as part of standard precautions. And just to reiterate, we will be sending the slides out after this. And then we have one last question. Does HibiCleanse kill it?
Off the top of my head, I cannot answer that. I'm so sorry. There are actually 37 products on list P, which is pretty cool. You can go on to epa.gov and look up that specific list. I will definitely drop a link in here that will take you straight to list P so you can get going with your preparation for that. Good question though.
Super. Well, your timing's perfect. It's 3 o'clock on the dot. Thanks again, everyone, for joining today. I'm seeing additional questions in the chat. I'm happy to stay on if people have time to answer these, but I want to defer to the HAI team.
Hi, Jackie, this is Becca. I think we'll just take this list of questions back and make sure we circle back. I think it's a good question about CHD and HIPAA cleanse and not a super simple answer. So we can provide that when we send out slides.
That sounds great. Thank you. So thanks, everyone. Have a great rest of your day.